Bismillah ar-Rahman ar-Rahim. Today our lecture is talking about acute leukemia presented by me, Dr. Inas Abdul Karim Al-Saadi, me a lecturer of hematopathology in the College of Medicine, University of Karbala, and have a fellowship of Iraqi Board for Medical Specialization. First, we have to know the objective of this lecture. It's important to understand the etiology of and definition of acute leukemia and the different scheme of leukemia classification, clinical feature and lab finding of acute myeloid leukemia and acute lymphoblastic leukemia, and lastly we have to know the difference between leukemia and lymphoma. Acute leukemia definition, we have to know what is the meaning of acute leukemia. In Arabic it means سرطان الدم, so it is one of the hematopoietic malignancy. It is an aggressive clonal malignant transformation involving the hematopoietic stem cell or early progenitor blast and characterized by uncontrolled proliferation of blast cell in the bone marrow with spillage into peripheral blood and variable infiltration of other organs. It is aggressive. Aggressive means إدائي أو عدواني. Clonal means derived from this word come from the word clonality. Clone means derived from one population, one group of cell which have been developed and derived from one ancestry. So it is malignant condition involving one clone of cell. This cell either the hematopoietic stem cell اللي هي الخلايا الجذعية اللي لها القابلية إلى التماثل أو التمايز إلى مختلف أنواع خلايا الدم اللي هي RBC, white BC and platelet. اللي هي stem cell has the capacity of self-renewal, تجديد data and differentiation into many types of cell. Accordingly, they can differentiate into red cell and white cell and platelet under the influence of many growth factors. أو involving the early progenitor cell اللي هي البلاست cell, primitive cell. blast cell they are primitive cell, خلايا بدائية غير متطورة، غير ما صاير بها maturation. early الخلايا المولدة الأولية. لذلك المرض result by uncontrolled proliferation. If it was controlled, we said that it is uncontrolled because it is any malignancy. It is uncontrolled maturation, proliferation, uncontrolled growth. If it is controlled, mean physiological. When I said uncontrolled, mean pathological condition. So uncontrolled proliferation of these blast cell presented in the bone marrow, and then they spill into peripheral blood and variable infiltration of other organ. This proliferation in the bone marrow and spillage in the peripheral blood and infiltration into other organs will forming the and responsible for the clinical feature of a patient with acute leukemia. Also, they result from a series of genetic alteration rather than one single event. So multiple genetic sequences occur leading to the development and appearance of acute leukemia rather than a single event. This alteration either involving the proto-oncogene or a tumor suppressor gene. If proto-oncogene involved, this means it is proto-oncogene, means stimulant gene. It is a stimulant gene. When it is involved, so it's become hyperactive, stimulate further and further proliferation of these blasts. Or involving the tumor suppressor gene. Tumor suppressor gene, when undergone mutation or genetic alteration, this means that from its name, tumor suppressor, its function is to suppress the tumor activity, the malignant activity. When the mutation involved, its activity becomes subside or reducing. That's why allowing the proliferation and of the malignancy and growth of the malignancy to continue more and more, resulting, as we mentioned in the lecture, in the abnormal and uncontrollable proliferation of the malignant cell, the blast cell, in the bone marrow and other sites of the body. Regarding the types of acute leukemia, we have two major types. The most important, it is the acute lymphoblastic leukemia. From its name, lymphoblastic means the malignancy or the tumor involving the lymphoid series. And this also it is divided either into T acute lymphoblastic leukemia or B lymphoblastic leukemia. In normal condition, we have two types of lymphocytes, either T lymphocyte or B lymphocyte, and this division according to the markers that the lymphocyte carry on its surface which we detect it by immune phenotyping by flow cytometry. If the lymphocyte carrying the marker of T cell, which are like CD2, cluster of differentiation number 2, we name it, and CD3, CD5, CD8, these are CD7, these are marker of T lymphocyte. We then put it in the part of T cell, while when it is carry markers of B lymphocyte, B lymphocyte carrying a marker such as cluster of differentiation, yani CD, cluster of differentiation, C from the early name of a cluster, and D the beginning or the first letter of differentiation, so name it مختصر CD, CD10, CD19, CD20, these are marker of B lymphocyte. If we find this marker by flow cytometry on the surface of cell, we name it B lymphocyte. So also further on, if we find it on the malignant cell, in case of acute lymphoblastic leukemia, we name it B acute lymphoblastic leukemia, and so on. Or it is acute myeloblastic leukemia when the blast cell or malignancy involving the myeloid series. The third type, so the two main types are acute lymphoblastic leukemia and acute myeloblastic leukemia. We have another type which is result from mixture of both lymphoblastic series, lymphoid series, and myeloid series. When we found two population of the blast of the malignant cell in the peripheral blood or in bone marrow, we name it mixed lineage, biphenotypic or bilineage lymphoid leukemia. ومثل ما قلنا شلون أعرفهم according to the either the morphology. We found two population regarding the morphology, see that the blasts are lymphoid and myeloid, two population, and confirm our diagnosis by flow cytometry or by when we found two markers, the blast that carrying the lymphoid markers on its surface and the blast that carrying the myeloid marker. By this type we confirm the diagnosis that it is a mixed lineage, biphenotypic or bilineage leukemia. What is the etiology of acute leukemia? Why it is developed? It is mean exposure to either one of these factor or agents. First, environmental agent, exposure to ionizing radiation, or exposure to chemical such as chronic exposure to benzene may aid in the development of acute leukemia. Second, host susceptibility, يعني الhost نفس patient has a factor, either genetic factor or acquired factor. We mention it in details soon. Oncogenic viruses, also some viruses, when the patient or the person exposed to them has the capacity to initiate the malignant transformation and uncontrolled proliferation of the cells. Regarding environmental agent, as we mentioned previously, exposure to radiation, as it has been noticed that there is increased incidence of all types of leukemia in survivors of atomic bombing in Japan. القنبلة الذرية اللي صارت قبل فترة من الزمن في اليابان، لاحظوا إنه increased incidence of all types of leukemia in those that exposed to this atomic bombing and radiation. Other, it is alkylating agent like chlorambucil and mustine, especially when they have been compound. This type of chemical agent, when person exposed to them, they initiate the development and malignant proliferation and development of leukemia. Another, it is a genetic factor of the host. There is increased incidence of leukemia in some genetic diseases or syndromic diseases. Down syndrome, متلازمة Down, Bloom syndrome. This syndrome, متلازمة Bloom's, means the patient has many criteria, such as has involvement of more than one system in its body. Skin rash, has a photosensitivity, has immunological disorder, and so on. Fanconi anemia, which is form of aplastic anemia, and bone marrow failure syndrome. Also, these patients has increased susceptibility for development of leukemia. Ataxia telangiectasia, which is a neurodegenerative disease characterized by involvement of nervous system, immune system, they have a difficulty in coordinating movement. Klinefelter syndrome, also we name it XXY47, means it is occur in male and they have more X chromosome, and usually it is characterized by infertility, those patients. Also this patient and this syndrome has increased susceptibility for development of acute leukemia. Regarding acquired factor, also a patient may have any disease. The presence of such a disease or such a condition, also the patient has more susceptibility for developing acute leukemia, such as myelodysplasia, or name it myelodysplastic syndrome. It means تشوهات متلازمة خلل أو تشوه النسيج النقوي أو النخاعي بالعربي. Secondary AML after chemotherapy and plus minus radiotherapy, as we mentioned it. Patient has a chemotherapy and then will develop AML secondary to this exposure to chemotherapy. Myeloproliferative disorder اللي هو مرض التكاثر النقوي, CML, chronic myeloid leukemia. Even it is cancer, but a patient with this can develop another form of another malignancy, hemopoietic malignancy. Polycythemia rubra vera, also I think it is a form of myeloproliferative disorder, and I think we will take it in another lecture inshallah. And myelofibrosis, تليف النسيج النقوي, أيضا it is a form of myeloproliferative disorder. This group of disorder mainly develop acute myeloid leukemia. Aplastic anemia, also it is a form of bone marrow failure syndrome. These more liable for development of acute myeloid leukemia. Paroxysmal nocturnal hemoglobinuria, it is a form of hemolytic anemia characterized by many features: hemolysis, an increased tendency for thrombosis, and renal failure, and usually it is occur due to mutation of one gene that responsible اللي هو phosphatidyl inositol protein, phosphatidyl inositol protein اللي هو responsible for stabilization of the protein on cell surface on the red cell membrane. So if there is any mutation in this protein, this result into this form of anemia, hemolytic anemia, acquired type of hemolytic anemia. As we mentioned, the patient has hemolysis and increased tendency of thrombosis and renal failure. These patients will have increased tendency of development of acute myeloid leukemia. Multiple myeloma اللي نصيح لها الورم النقوي المتعدد, which is a form of plasma cell dyscrasia, plasma cell malignancy involving the plasma cell. Also these has increased tendency for developing of acute myeloid leukemia. Then oncogenic viruses, not all viruses, we have some example for the viruses that when involve the patient or infect the patient, this patient will have more and more increased tendency for developing leukemias, like human T-cell lymphoma virus type 1, which is a cause of adult T-cell leukemia lymphoma. Epstein-Barr virus associated with endemic form of Burkitt lymphoma, which is African type. AIDS also, which is caused by HIV, human immune deficiency virus, associated also with increased incidence of lymphoma. This is information for you that the incidence of acute myeloid leukemia increased about 1.3 to 2-fold in smokers, presumably because of exposure to carcinogens such as benzene and tobacco smoke. Pathogenesis, how the leukemia develop. As we mentioned that the leukemia, it is an aggressive disease in which malignant transformation occur in the pluripotent hemopoietic stem cell or very early progenitor. Thus, the genetic damage may involve different key steps in cell proliferation and differentiation. It is either result into increased rate of proliferation or reduce apoptosis, which is a form of programmed cell death when it is reduced, when the cell death reduced. So On the other side, there will be increased proliferation and development of the malignant condition. Or involvement the blockage in the cellular differentiation. This is the pathogenesis and how the leukemia develop. Either increased rate of proliferation or reduced rate of apoptosis or block in cellular differentiation. Clinical manifestation, clinical feature of patient with acute leukemia. Acute leukemia could be developed at any age, and we can classify them into two distinct types. We have childhood leukemia, which is affected children less than 15 years old. 80% of these cases are usually acute lymphoblastic leukemia. Or adult leukemia affecting adults more than 15 years. The majority of the cases are acute myeloid leukemia. As a clinical presentation, there is a great degree of overlap between acute myeloid and acute lymphoid leukemia. Thus, it is requiring many investigation for accurate categorization. إذن إحنا يعني بالclinical manifestation أقدر أقسم اللوكيميا according to the age involved. Either childhood leukemia اللي هم أقل من 15 سنة واللي هي أكثر شيء ALL. 80% of the cases are usually ALL. أو أقسمها إلى adult leukemia in which it is affect adult more than 15 years old, while majority of them are acute myeloid leukemia. غالبا clinical presentation it is difficult to distinguish or differentiate between acute myeloid leukemia patient and acute lymphoid leukemia patient. لذلك أحتاج إلى investigation اللي إن شاء الله نمر على ذكرها في السلايدات المقبلة. Okay. Also, we still in speaking about the clinical manifestation. The onset is either sudden, especially in children, or insidious. Clinically, acute myeloid leukemia and acute lymphoid leukemia are indistinguishable, as we mentioned previously. Apart from free exception, some form of leukemia has special characteristic or special clinical feature occur in patients involved with them, such as gum hypertrophy is more common in certain subtypes of acute myeloid leukemia, such as monocytic acute myeloid leukemia اللي هي Unn4 subtype والUnn5 subtypes that we will mention them later on, and lymphadenopathy more common in ALL. When I said gum hypertrophy is more common in certain subtypes such as Unn4, Unn5, this is not mean that another type not occur in them. No, but it is more common in them more than another type of other subtypes of acute myeloid leukemia, and so on. The common symptom and sign at presentation are mainly a result of, from or related to the proliferation of leukemic cell and their infiltration into normal tissue, as we mentioned in the definition of acute leukemia. First, the bone marrow failure. This feature, clinical feature related to the bone marrow failure. It is either anemia. First of all, anemia, which is a common feature occur in patients with hematopoietic malignancies in general. Patient with anemia has a pallor, has a weakness, has fatigability, dyspnea, lethargy, and usually dyspnea on exertion. Even may have angina, even may have also palpitation, اللي هو الخفقان. Okay, these are pictures show us the clinical feature and clinical presentation in some forms and some subtypes of anemia, such as here infection. It is so common due to reduced immunity, especially neutropenia. Neutropenia, we see it, and it is occur in malignancy, so there is reduction in the immunity of the person, leading to infection. Bleeding manifestation of acute leukemia in the skin, purpura and ecchymosis. Here is ecchymosis, here is purpura crash. Due to reduced platelet, thrombocytopenia. Cervical lymphadenopathy, here, cervical lymphadenopathy is so clear here, common in ALL. Gum hypertrophy, as we mentioned it, common in AML. Unn5, and as we mentioned previously, Unn4 could be seen. Unn5 mean monoblastic leukemia. It's form subtype of acute myeloid leukemia. How can we diagnose patients with acute leukemia? First of all, we need the presence of more than or equal 20% of a blast in the bone marrow and or in the peripheral blood. يعني إذا لقيت 20% of a blast in peripheral blood, it is acute leukemia. In general ده أحكي acute myeloid or acute lymphoid leukemia. Acute leukemia, for to be diagnosed, I need first of all presence of a blast cell, the malignant cell. I need their presence, and they need to be more than or equal 20% in the peripheral blood or in the bone marrow or both of them. Okay, however, it can be diagnosed with even less than 20% of blast. In which situation? In general أنا أحتاج 20% أو أكثر من 20% of blast in the peripheral blood and bone marrow or one of them. إذا ما لقيت 20%, but I have suspicion from clinical picture that the patient have a leukemia. أقل من 20%, it is enough, yes, but in a specific situation, such as specific leukemia associated cytogenetic or molecular genetic abnormality if present, like translocation 15-17 in case of acute myeloid leukemia M3. إذا يعني أقدر أشخص اللوكيميا إذا الكاونت كان أقل من 20% في حالات معينة. إذا عندي leukemia associated cytogenetic abnormality, there are specific cytogenetic abnormality. When they are present, they are related to specific subtypes of leukemia. When I found 15 translocation of 15-17, even if it blast less than 20%, this is mean it is acute myeloid leukemia M3. Acute Bromylocitic leukemia. First, blood film, RBC, as we mentioned that anemia, it is almost always present and usually normochromic normocytic anemia, usually. White BC, the total white BC count variable. This may be either leukocytosis, the leukemia, the patient with leukemia may be presented with leukocytosis, and even the leukocytosis may reach to very, very high count, like 200 to 300,000 cell, where blasts are self-evident. أكيد إذا عندي leukocytosis reaching this high number, أكيد the blast will become evident and clear, and I see it so prominently. Or leukopenia, yes, the patient, if the bone marrow suppression is so severe, I can't find the patient with leukemia but has a leukopenia. In this case, even the blast not so evident as the patient with leukocytosis. I found it in the peripheral blood, but not so evident. Or it may show normal count. Even patient come to me, CBC has a normal count, but when I come to the blood film and do differential, I found blast 20% or even more than 20%. Then it's diagnosed as acute leukemia. Neutropenia also common finding in the peripheral blood. Platelets. Regarding platelets, it's usually thrombocytopenia in most cases in which the platelet count reduce or decrease less than 150,000 count. This is a slide showing acute leukemia. How we can know from the morphology it is acute myeloid or acute lymphoid leukemia? Here it is definitely acute myeloid leukemia because the presence of this granule, you see it, it is our rod, we name it our rod. It is more pathognomonic and specific to the blast of acute myeloid leukemia. In general, here these are all of these cells are blast, leukemic cell. How can we describe them? These are cells with large primitive cell. Primitive معناها this is the chromatin, open chromatin, not condensed, not a clump. You see it, it is احنا نصيح لقطعة وحدة open chromatin, so it is immature cell. Large cell with high NC ratio, NC nucleus to cytoplasmic ratio. Nucleus, it is large in relation to the cytoplasm. I said them, they are cells with high NC ratio, high nucleus cytoplasmic ratio. They have multiple nucleoli. You see, this is a nucleolus, these are, and showing our rods, which is granular structure, maybe Many studies show that it's maybe structure dislodged from nuclear structure or chromatin structure. So it is a granular structure. So this is definitely, it is acute myeloid leukemia. Second, first, we mentioned that we have to depend on the blood film and CBC and blood film, then bone marrow aspirate. In the bone marrow aspirate, it is necessary to confirm our diagnosis, especially when we have low count. مثل ما قلنا قبل شوية انه ممكن هو ليكوبينيا وموجودة بلاست بالبيرفرال بلاد بس البلاست ما حققت لي 20%. How can I confirm? I have to confirm that it is leukemia, and I have to blast. I have a number of blast more than 20 or more than 20 to say that is leukemia. So that I have to go to the bone marrow aspirate and check the number of blasts. When I go to the bone marrow and calculate the blast and found them 20% or more than, so definitely it is acute leukemia. So the marrow is usually markedly hypercellular with extensive infiltration by blast cell constituting at least 20% of all nucleated cell. Of all nucleated cell mean erythroid and myeloid series with suppression of normal hemopoietic elements. Means I will find the blast forming about 20% of all nucleated cell. With suppression mean I will may found or may not found the normal series that should be found in a normal patient, a normal situation, a normal condition, whether early precursors such as bromylocite, myeloid, or late mature cells such as neutrophil, basophil, I will find them in very few number, means there is a suppression. Or even sometimes when there is extensive infiltration, I said that there is the leukemic infiltration suppress other hemopoietic element. There is no normal hemopoietic element. This is showing that the disease is so aggressive and so extensive, that's why it's suppressing other hemopoietic elements. Based on morphology of the blast and their pattern of maturation and the use of special stains, sometimes immunological marker, leukemia could be classified into lymphoid and myeloid subtype and subtype within each of these classes. We are still in the bone marrow aspirate. First I check the blood film, and then from the blood film I have a suspicion because I see the blast. Then I will go to the bone marrow aspirate and also see these blasts. But I have to confirm my diagnosis, see the subtype of the blast, whether it is a myeloid or lymphoid. How? I will depend then on the special stains. I have a special stain and have a cytochemistry that can give me the diagnosis and confirm my diagnosis, in which such as we have periodic acid Schiff stain, periodic acid Schiff stain, PAS. It is if I do it and was positive, it is mean that it is lymphoid series. While if I do another stain such as myeloperoxidase or Sudan black stain, this means that it is a myeloid series, myeloid leukemia. Then also I can confirm by another way, which is as I mentioned, immunological marker by flow cytometry or immune phenotyping, in which as I mentioned previously that we have some immunological marker specific for lymphoid series, whether T lymphoid or B lymphocytes. Also there is specific marker specific for myeloid series. Depending on these marker, I can then say whether it is acute myeloid leukemia or acute lymphoid leukemia, and so on, or by phenotypic as we mentioned previously. Then third step, we have bone marrow to refine biopsy. After I do bone marrow aspirate, then I can do bone marrow to refine biopsy, but in special situation it is of secondary importance. When the peripheral blood feature not diagnostic and bone marrow aspirate difficult or impossible to be done, it is can be essential for diagnosis. In which situation, when the bone marrow aspirate is inadequate, this is commonly due to increased either reticulin fiber or collagen, marrow fibrosis, and or dense cellular infiltration. This is rarely to be seen. So I do bone marrow trophine biopsy when the bone marrow aspirate is inadequate to be studied and to be checked. When there is bone marrow fibrosis, طبعا special type of leukemia or hematological malignancy, bone marrow get fibrosed, so I can't get enough amount to be studied and give me the idea about the cellular content of the bone marrow aspirate. As we mentioned, reticulin fibrosis such as in the M7 acute myeloid leukemia, megakaryoblast leukemia subtype. This is usually associated with fibrosis, and my diagnosis usually don't depend and don't rely on bone marrow aspirate. Usually I depend on another rules such as immune phenotyping. Even sometimes bone marrow biopsy can give me some finding such as the fibrous tissue fibrosis, and as it is megakaryoblast leukemia means the megakaryocytes are hyperactive. I see them hyperactive and more predominant in the bone marrow aspirate, in the bone marrow biopsy. Second, to distinguish poor aspirate due to hypocellularity from one with persistent leukemia, hypoblastic AML have been defined as AML with bone marrow cellularity less than 40 to 50%. Also, bone marrow trophine biopsy I can do it to حتى أميز البور aspirate اللي عندي هو نتيجة الهايبوسيلولاريتي. أكو عندي hypoblastic AML. إذن هذا البور aspirate هو نتيجة الهايبوبلاستيك AML اللي هي البون مارو cellularity less than 40 to 50%, or it is due to persistent leukemia. Third, it is also I can use bone marrow trophine biopsy to follow the effect of treatment, particularly in the AML. يعني نشوف مثلا patient I give him treatment, I want to follow him. He was a patient in the biopsy previously has a fibrosis and has less cellularity. Then I do bone marrow trophine biopsy and see. I see if there is a good response, I will see that there is regression in the fibrotic tissue and more cellularity become predominant and so on. This is a picture or figure for you to see how the cellularity appear in the. This is a trophine biopsy. See here, how the cell have been. There is diffuse infiltration of mononuclear cell, monotonous cell here in the bone marrow biopsy. طبعا this is a mega karyocyte. Okay. The second or another step or tool for the investigation, it is a cytochemistry. As I mentioned previously, we have some cytochemical stain I use and I depend on them to differentiate between acute myeloid leukemia and acute lymphoblastic leukemia. Here the cytochemistry, it is selective, useful if leukemia is not obviously myeloid. If I have a slide and check it and I do CBC, I do blood film, and I do bone marrow aspirate, and I am still in query. I don't know, because the morphology is not so helpful, not help me to differentiate or not conclusive. I can't from it know whether it is acute myeloid or acute lymphoid leukemia. I can do cytochemistry if the leukemia is not obviously myeloid or lymphoid. Nowadays it have been declined in importance since there is a development and availability of immune phenotyping, which is flow cytometry, that can give me the or confirm the diagnosis depending on the immunological marker that I use them to know whether it is acute myeloid or acute lymphoid leukemia. But also I can use them when the flow is not available or not ready and not rapidly accessible. I can use cytochemistry in this situation. As I mentioned, immune phenotyping, which is indicated in all patients in whom the leukemia is not obviously myeloid by using specific immunological marker. Cytogenetic analysis is essential in all patients since knowledge of the karyotype is important for determining the prognosis and for choice of optimal treatment. It is best performed on bone marrow aspirate. If the count is so high in peripheral blood, I can take a sample of peripheral blood. Other forms and tool for the investigation, it is radiological examination. What I find by radiology, I may find lytic bone lesion resulting from infiltration of these malignant cells into the bone, forming lytic bone lesion. Mediastinal widening, which is characteristic and pathognomonic for the T-cell acute lymphoblastic leukemia, in which there will be enlargement of the thymus and or mediastinal lymph node enlargement. Another, it is lumbar puncture for Csf examination. Csf, cerebrospinal fluid, may show the cerebrospinal fluid contain leukemic cell and indicate CNS involvement. عادة أشوفها في some form of leukemia. أحيانا مثلا acute lymphoblastic leukemia. Patient with acute lymphoblastic leukemia diagnosed, and then he is suffering from CNS manifestation, severe headache, diplopia, whatever, any signs of CNS involvement, then I have a suspicion that he have CNS dissemination of this malignancy. Thus I take CSF fluid and check it under microscope. When I found malignant cell infiltrate, even sometimes in sheet or in severe cases as a diffuse infiltration. Accordingly, if I found them, this is mean that the patient has CNS infiltration and CNS manifestation due to malignant infiltration of these cells to the CNS system. Another biochemical test, any malignant condition, usually we will see biochemical changes such as increased uric acid, lactate dehydrogenase enzyme, hypokalemia may be spurious when the white BC count is very high. Also hypercalcemia, I found it, as we mentioned, especially if there is lytic bone lesion. So it is clearly that there will be hypercalcemia will be seen. Coagulation tests, usually not in every situation. Some situation, coagulation tests, I need them when I have suspicion, usually of acute myeloid leukemia, M3, acute promyelocytic leukemia. Usually these patients with acute promyelocytic leukemia, M3 subtype, have manifestation and presentation of DIC, disseminated intravascular coagulation. Come to the specialist with a manifestation of a bleeding tendency, such as ecchymosis, epistaxis, whatever. When I have a suspicion of this, I have to of acute myeloid leukemia M3, thus I will need coagulation test. And usually I will find that there is a picture, coagulation test suggestive of DIC, disseminated intravascular coagulation, prolongation of PT, PTT, bleeding time, and increased D-dimer, and so on. What is the classification and what is it is based, the classification of leukemia, acute leukemia, usually it is, when I classify them, I base on many features, on many features I depend on them, such as the morphology of the blast, blast, cytochemistry that I speak about them previously, SPB mean Sudan black stain, which is suggestive or specific for myeloid leukemia, BAS, periodic acid shift, which is usually it is specific and pathognomonic for acute lymphoblastic leukemia, NPO, myeloperoxidase stain, esterases, especially non-specific esterases. Usually these are stained for subtype of acute myeloid leukemia, which is M5, acute monoblastic leukemia. Esterases are specific for them. When they are positive, usually it is suggestive either of M4 or M5, acute monoblastic leukemia. What else also I depend in the classification? I depend on the immune phenotyping. Also on the genetic analysis, including cytogenetic techniques such as FISH or cytogenetic analysis of cell in metaphase. طبعا الميتافيز، طبعا الفيش هو ممكن استعمله، ممكن هو cytogenetic and molecular technique بنفس الوقت. It is so useful because it can diagnose the cell in metaphase or interphase. So it is so suggestive and so important and useful in our society in the diagnosis, reaching the diagnosis of acute leukemia. Molecular genetic technique like reverse transcriptase polymerase chain reaction, RT-PCR. This is the Fab classification, French, American, British classification. Fab احنا صيح له, we name it, we call it Fab classification. This is so common. This is based on the morphology of the blast and on the use of special stain cytochemistry and limited use of monoclonal marker in special situation, immunophenotyping. Accordingly, acute leukemia is classified and sub-classified into first acute lymphoid leukemia. احنا نقسمها حسب الفاب classification إلى 3 subtypes, L1, L2, L3. Depending on the morphology, we mentioned that Fab classification, it is according to morphology and cytochemistry and limited use of قليل اعتماده على أكثر شيء على morphology و cytochemistry and limited use of monoclonal marker in special situation using immune phenotyping. So acute lymphoid leukemia classified in 3 subtypes, L1, L2, L3. While acute myeloid leukemia classified into 8 subtypes, M0, M1, 2, 3, 4, 5, 6, 7. This is the Fab classification. First, we will start with acute lymphoid leukemia. As we mentioned previously, it is divided into 3 subtypes. According to what? According to the cell size, lymphoblast size, according to their nuclear chromatin, whether it is clumped chromatin, condensed, يعني متجمع تحسه, or whether open chromatin. Also, depending on the nuclear membrane shape, whether regular or irregular membrane shape, according to the nucleolus, it is present, absent, it is inconspicuous, نصيح لها غير واضحة المعالم. Amount of cytoplasm, whether scanty cytoplasm, more cytoplasm. It is also depending on the cytoplasmic basophilia, whether the blast it is deeply basophilic or less basophilic, and also according to the cytoplasmic vacuolation. As vacuolation means the blast cell contain vacuoles حويصلات احنا نصيح لها باللغة العربية. If it is present in large number, this is usually suggestive of acute lymphoblastic leukemia, all 3 subtypes, and then we will mention it later on. First, L1, usually the blast it is monomorphic, يعني قطعة واحدة متماثلة الأشكال. blast عادة تجي متماثلة من ناحية الحجم، من ناحية الشكل. Majority small, high nucleocytoplasmic ratio, high NC ratio, scanty cytoplasm, كمية السيتوبلازم قليلة, small or inconspicuous nucleoli. يعني small مثل ما قلنا inconspicuous ممكن تكون قد تكون واضحة أو قد تكون غير واضحة. ال L2 heterogeneous blast، يعني بلاست مختلفة بأشكالها وبأحجامها، عكس ال L1 اللي هي قلنا monomorphic تكون، هذه مختلفة بأشكالها وبأحجامها. variable sizes مختلفة قلناها. NC مختلفة من ناحية ال NC ratio ومن ناحية ال size. more prominent nucleoli، بينما قلنا بال L1 تكون ال nucleoli inconspicuous or small، بينما هنا prominent nucleoli. nuclear membrane irregularities، هناك يعني تقريبا regular، الممبرين يكون regular، هنا nuclear membrane irregularity. L3 monomorphic large blast، monomorphic large blast with prominent nucleoli and strongly basophilic vacuolated cytoplasm اللي حكينا قبلها. هذه تقريبا ال L3، يعني أني أجزم عليها بس مجرد ألقى ال vacuoles present in prominent and high vacuolation deeply basophilic cytoplasm, it is suggestive of acute lymphoblastic leukemia L3. Okay. Also, this depending on the Fab classification, morphological feature. As we mentioned, this table it is the same speech L1, L2, L3 regarding cell size,
L1 we mentioned that it is small, while L2 large heterogeneous, 3 large heterogeneous. Nuclear chromatin, it is in L1 fairly homogeneous, may be condensed in some cells. homogeneous يعني متماثل، قطعة واحدة، ما بي clumping. L2 heterogeneous يعني nuclear chromatin تقريبا heterogeneous يعني مختلف، تحسه مو قطعة واحدة، احنا نصيح له. L3 finely stippled homogeneous. Nuclear shape may be irregular in L1, irregular and clifting. There is nuclear clifting يعني احنا نصيح لها مثل الطعجة باللغة العربية. Indentation common. Regular oval or round in case of L3. Nucleolus not visible or small and inconspicuous in case of L1, while usually visible, often large in L2 and usually prominent in L3. Amount of cytoplasm scant in L1, variable, often abundant in L2, moderately abundant in L3, and cytoplasmic basophilia slightly to moderate in L1, variable in L2, strong in L3, and vacuolation variable in L1, variable in L2, and often prominent in L3. يعني ممكن أنا أشوف case L2 بيها vacuolation but very يعني نقول عليه very small. يمكن ألقى لي بلاس وحدة بيها vacuolia وحدة، vacuoles وحدة، هذه not ما أقدر أجزم عليها وأقول. بالإضافة نحتاج باقي الكرايتيريا، إحنا قلنا deeply basophilic، large blast، another وأكو طبعا special stain oil red O بالL3. هذه إذا أسويها عندي suspicion of L3، إذا طلعت الoil red O positive this is mean suggestive of L3. لذلك أنا مو بس دائما أعتمد على المورفولوجي، أكيد على السايتوكيمستري، وإذا السايتوكيمستري ما وصل لي للدايجنوسيس الصحيح التجئ للخطوة اللي بعدها اللي هي الاميون فينوتايبنج فلو سايتومتري، وأسوي الماركرز اللي أني يعني مخليتها ببالي مثلا whether lymphoid or myeloid، وذاك الوقت أقدر أجزم وأنطي الدايجنوسيس النهائي. L1 subtype monomorphic blast, majority small. This is a small. High NC ratio. شوف high NC ratio nucleus, it is large in relation to the cytoplasm, scanty cytoplasm, we see that. High NC ratio. Small or inconspicuous nucleoli, تكاد تكون لا ترى. مثلا هذه نصح لها inconspicuous nucleoli، موجودة أو ما موجودة عندي شك بيها، مو كلش واضحة. هذه مثلا inconspicuous nucleoli موجودة، هذه تقريبا يعني إلا واحد يركز، هذه غير واضحة، إلا يعني تحتاج تركيز، موجودة أو ما موجودة، يعني مرات حتى واحد عنده شك نصيح لها inconspicuous nucleoli، small or inconspicuous nucleoli. أوكي، بينما هذه شوف L2، شوف النوكليولاي it is heterogeneous blast، مختلفة بحجمها، بالسايز مختلفة، وبالانسي ريشيو مختلفة. قسم هاي انسي ريشيو، هاي انسي ريشيو. شوف النوكليوس large in relation to the cytoplasm، بينما هذه لا، موجود اكو cytoplasm، اذا مختلفة بيها. شوف هاي حتى indentation، اكو clefting. زين، هاي النوكليولاس واضحة prominent، بينما ذيك كانت inconspicuous nucleoli or even small. So they are heterogeneous, variable sizes and NC ratio with more prominent nucleoli and nuclear membrane irregularities. شوفي هذه irregular nuclear membrane، هذه nuclear membrane irregularity، بينما ذيك كانت لا، قطعة واحدة homogeneous. هذه ال L3 اللي هي monomorphic large blast monomorphic، تقريبا شكلها واحد موحد with prominent nucleoli. هذه prominent nucleoli واضحة تقريبا، هذه nucleoli. زين، واللي يميزه واللي يخليني انطي التشخيص النهائي هي طبعا ديبلي بيزوفيليك سايتوبلازم، بيزوفيليك يعني على زراق، احنا نصيح له ديبلي بيزوفيليك فعلا، ازرق طوخ with vacuolated cytoplasm. هذه يعني هاي اجزم عليها L3. it is more prominent vacuolation than other types of lymphoid leukemia or acute leukemia in general. I am still in the Fab classification now. In the acute myeloid leukemia, it is divided into 8 subtypes from M0 to M7. M0, it is acute myeloid leukemia with minimal evidence of myeloid differentiation. M1 without maturation, M2 with maturation, M3 acute bromylocitic leukemia, M4 acute myelomonocytic leukemia mean I have both myeloid series and monocytic series in the field. M5 acute monoblastic leukemia, the monocytic series become more prominent here than the M4. 4 has a mixture of myeloid and monocytic. طبعا bromylocitic leukemia من اسمها bromyloid. The involvement here, there will be maturation and rest at bromylocytes step. We know that the sequence of differentiation and maturation starting from the stem cell, blast, bromylocyte, myelocyte. So it is till it is continue till it reach to the mature cells such as neutrophil, basophil, and so on. So it is here acute bromylocytic leukemia. The involvement and the maturation arrest will occur at bromylocyte. So the prominent cell that I see them, bromylocyte, will not found other sequence later sequences such as the mature cell neutrophil, and there is a maturation arrest and the prominent cell will be bromylocyte. There will be malignant bromylocyte in this form of leukemia. M6, it is acute erythro leukemia, means it is involving the erythroid series. I will find erythroblast and myeloblast in this form of leukemia according to the criteria of this type of leukemia. And lastly, M7, it is acute megakaryocytic leukemia. This form of leukemia involving megakaryocytic series. So I will found the megakaryoblast and myeloid blast also. I will found them in this form of leukemia. Fab classification, Aml morphological feature. I tell you previously that when I found this our rod, this is suggestive and pathognomonic of acute myeloid leukemia. This is a feature of blast of acute myeloid leukemia. High NC ratio. They are usually the heterogeneous blast, different, variable in size and shape, open chromatin, and as we said previously, our rod, it is suggestive of acute myeloid leukemia. This our rod, distinctive red staining rod, seen in cytoplasm of myeloblast, representative abnormal eosinophilic granules. They are diagnostic of acute myeloid leukemia. M0, acute myeloid leukemia, as we mentioned, with minimal evidence of differentiation. This is M0. Immune phenotyping, as we mentioned previously, flow cytometry, it is done by applying certain monoclonal antibody that recognize specific antigen, whether nuclear, cytoplasmic, surface antigen. This is very valuable and effective and efficient in distinction between myeloid and lymphoid leukemia, and between even different subtypes of leukemia, whether between subtypes of acute myeloid leukemia or subtypes of acute lymphoid leukemia. Also, it is useful in treatment and follow-up in determining a prognosis. Treatment and follow-up. There are certain markers that are specific for each cell line. For example, cytoplasmic myeloperoxidase is the most specific for acute myeloid leukemia. CD79A for BALL, cytoplasmic CD3 for TALL. And there are many other markers that can be used for further categorization. So immune phenotyping is highly suggestive. It is so important and is more valuable in distinction between myeloid and lymphoid leukemia, and even between subtypes of acute leukemia itself, depending and by applying a marker, monoclonal antibody that targeting specific antigen, whether this antigen nuclear or cytoplasmic or surface antigen, and by this I can confirm my diagnosis that I put in mind by morphology or even by cytochemistry. What about cytogenetic abnormality in ALL? We have chromosomal abnormality usually found in about 80% of the cases. It's either numerical abnormality in the number of the chromosome or structural abnormality, means the translocations. So what are the numerical abnormality? It's either hyperploidy or hypoploidy. Hyperploidy means the chromosome more than 50 chromosomes. It has a good prognosis. When I found patient with acute lymphoid leukemia and have a hyperploidy by cytogenetic analysis, this means has a good prognosis. While regarding hypoploidy, which means that less than 45 chromosome, it is associated with poor prognosis. Structural abnormality, mainly translocations, inversions, deletion, hadith, point mutation, involving amino acid substitution, as mentioned it in another lecture. Some of the most common translocation is either translocation between chromosome 9 and 22, which is resulting in the formation of Philadelphia chromosome. It is characteristic of CML cases, chronic myeloid leukemia cases. This will be mentioned in another lecture. Seen in about 20% of the cases of chronic myeloid leukemia. It is more in adults and it is associated with poor prognosis. Another form of translocation, it is translocation between 4 chromosome and 11 with MLL gene rearrangement, most common infant associated with poor prognosis. And lastly, translocation between chromosome 12 and 21, and it is also carry a good prognosis. Translocation 12, 21 carry a very good prognosis. This is a karyotype example for hyperploidy of a patient with acute lymphoblastic leukemia, showing extra 4, 6, 8, 14, 17, 19, 21, and X chromosome, as it is appear here, chromosome 4. This is additional, should be there 2 chromosome here. There is additional chromosome 4, and chromosome 6, chromosome 8, 14, 17, and here 19, and here 21, and X chromosome also there is additional 1, should be there 1 chromosome. Here there is additional chromosome. Hypoploidy in a patient with ALL showing missing a chromosome 2, 3, 4, 12, 13, 15, 16, and 17. There is missing a chromosome. You can see it in this picture. It is clear. Regarding cytogenetic abnormality in acute myeloid leukemia, the chromosomal abnormality in acute myeloid leukemia is seen about 70% of the cases. Some of the structural abnormality in the AML is either translocation 821, which is present in 12% of the patient and associated with good prognosis, translocation 15, 17, Q31, Q21, 22, PAML, RAR-A, which is Bromylocitic leukemia gene, and retinoic acid gene, seen in about 25% of the cases of Bromylocitic leukemia and has a good prognosis. Other translocation that involve chromosome 17, like translocation 11, 17, may also be seen with a very variable response to ATRA drug, all trans retinoic acid drug. Inversion 3 or translocation 3, extremely poor prognosis, see it usually in acute megakardioblastic leukemia, M7. Inversion 16 or translocation 60 carries also good prognosis. Translocation between chromosome 9 and 22, the Philadelphia chromosome, characteristic of CML. When present in cases of acute leukemia, it carries a poor prognosis. When it's present, we have to know that translocation between chromosome 9 and 22, it is a characteristic and special feature for chronic myeloid leukemia, but it could be seen in cases of acute leukemia. So when it is present in cases of acute leukemia, it carries a poor prognosis. Translocation or deletion of chromosome 11 involve MLL gene, mixed lineage leukemia gene that are associated with poor prognosis. There are also many forms of numerical chromosomal anomalies that are associated with AML, such as trisomy or monosomy. Cytogenetic anomality are independent prognostic factors that have a great influence on the treatment outcome. Now let us speak about acute promyelocytic leukemia, M3. This type of leukemia, the malignant cell are the abnormal hypergranular bromylocyte. As I mentioned previously, from its name, it is acute promyelocytic leukemia, so the malignant transformation. And the most predominant cell are the malignant hypergranular bromylocyte. I will find them predominantly in patients with acute promyelocytic leukemia, M3. These cells characterized by having densely packed cytoplasm, densely clumped cytoplasm, deeply basophilic cytoplasm with granules, multiple our rods or vagot cell. احنا قلنا قبل شوية acute myeloid leukemia من أشوف بيها our rod when there is presence of our rod. This is pathognomonic of acute myeloid leukemia, not acute lymphoid leukemia. But when I found the subtype of acute myeloid leukemia have multiple our rods. يعني when I said multiple, many, 3, 4, 5, even 10 our rods. This is, I name it vagot cell. Here at least 3 our rod, at least, even I can find 4, 5, 10, at least 3 our rod per cell are seen. This I name them vagot cell. So what are vagot cell? Vagot cell, they are malignant bromylocyte that contain multiple granules, multiple our rods, at least 3 our rod per cell are named them vagot cell. This type of leukemia, the presentation usually dramatic. يعني تقريبا نقدر نقول fixed، تجينا نفس السيناريو. تختلف عن باقي التايب اوف لوكيميا. باقي التايب اوف لوكيميا قلنا مو ثابته، عاده indistinguishable clinical feature indistinguishable between acute lymphoid leukemia و acute myeloid leukemia. Even in the some subtypes of acute myeloid or lymphoid, I can't differentiate. While there it's usually fixed or the same scenario. Patients usually come with pancytopenia, high incidence of DIC, as I mentioned, disseminated intravascular coagulation. So the patients come with pancytopenia and bleeding tendency, epistaxis, menorrhagia for the female. Usually they come like this, ecchymotic bleeding, purpuric rash, and so on, bleeding tendency. And it is usually precipitated after treatment. This occurs because the cytoplasmic granules are rich with procoagulant material that will stimulate the coagulation process when released. يعني يقصد انه الدي اي سي ليش ده تصير؟ لانه هذه السيتوبلازميك جرانيول هي rich with procoagulant material اللي تحفز لنا changes and hemostatic abnormality and coagulation defect that appear as bleeding tendency. This is a picture suggestive of acute promyelocytic leukemia. Here, these are all of them malignant promyelocyte. We see this is the vagot cell. See multiple our rod. This multiple our rod. تقريبا هنا عندنا 1 2 3 4 5 6 7 8 9. يعني تقريبا حتى واصلة لل20 our rod. Okay, this is also multiple granules. It is deeply basophilic, dense clump cytoplasm. We see usually with indentation, promyelocyte nucleus here. It is highly indented. Okay, this is prominent nucleolus. When I see our rods like this, it is a vagot cell. Even this usually it is hidden the surface of the nucleus, multiple our rod. This is, I name it vagot cell. When I found it, it is highly suggestive of acute promyelocytic leukemia. Here, the characteristic feature of this type of leukemia, presence of translocation between chromosome 15 and 17, which is seen in the majority of the cases. About 95% of patients with acute promyelocytic leukemia having this translocation, which involve the retinoic acid receptor alpha gene on chromosome 17 and promyelocyte leukemia gene on chromosome 15. طبعا الretinoic acid receptor alpha gene, it is code for the retinoic acid receptor which induce cell differentiation. لذلك the translocation as this gene responsible for cell differentiation. So when it is undergo translocation, this result into reducing the function of this receptor, so no differentiation. So it will block differentiation and there will be maturation arrest, as I mentioned to you previously, at this stage at bromylocyte. However, still this translocation carries good prognosis. ليش؟ لأنه الابnormal receptor respond to high dose of ETRA, all trans retinoic acid drug. When I give this, it's usually this will induce the differentiation of the abnormal bromylocyte. لذلك عادة البيشنت رغم انه البيشنت يجي with a very severe bleeding tendency and patient usually came deteriorated, but usually احنا نتفائل لانه this type of subtype of leukemia carry a good prognosis because it is respond so rapidly and very good response to the ETRA drug, all trans retinoic acid, which will induce the differentiation of the abnormal bromylocyte. What is the how can be distinguished in general speak. طبعا الليمفوما راح تاخذوها محاضرات ان شاء الله كامله تعطى لكم في الاسبوع القادم ان شاء الله. لكن in general how can we distinguish between leukemia and lymphoma? Generally speaking, the distinction is that lymphoma, the disease started from lymphatic cell in the lymph node or other parts of the lymphatic system, while leukemia, whether acute or chronic, the disease start from lymphocytic cell in the bone marrow. يعني lymphoma من اسمها lymphoma هو malignancy of the lymph node, malignancy starting from the lymph node. زين يظهر عندي بالبلاد والبون مارو. بالبون مارو in the advanced stages it can invade the bone marrow, then after that there will be spillage of the abnormal lymphoid cell in the peripheral blood. إذن هو starting in the lymphatic cell. بينما باللوكيميا whether acute or chronic disease starting from the bone marrow, primary disease starting in the bone marrow, then it will be spilled, the malignant cell will be spilled in the peripheral blood and other organ causing manifestation. While in lymphoma it will start in the lymphatic system, in the lymphoid organ, in the lymph node, and then later on will be disseminated in the bone marrow with a spillage in the peripheral blood. In either case, the malignant cell can migrate from their source, bone marrow or lymphatic system, and be found in other sides of the body and other form of the other types of the organ, whether liver and spleen, and causing a clinical manifestation. Lymphoma, as we mentioned, these are malignant neoplasm derived from the lymphocyte that form tumors, usually in lymph node, but also in other organ or in soft tissue. Unlike the leukemia, that tumor cells don't appear in the blood in detectable numbers. The lymphomas are broadly grouped into two types: a non-Hodgkin lymphoma, 60%, and Hodgkin lymphoma, also known as Hodgkin diseases, 40%. Both lymphocytic leukemia and lymphoma are the result of malignant transformation of cell destined to be a lymphocyte. And thank you.